you so much for joining us during our OHA 1959 office hours for residential settings and community mental health programs. We are seeing a bigger crowd today. I'm very happy for that. I want to welcome everyone. In the past 6 months, this space has been providing essential support and technical assistance to 1959 providers, primarily focusing in community mental health programs. And we are very excited to continue that mission while expanding our reach to include residential providers who have expressed a need for support. Could we start the presentation, please? Go ahead, one more slide, please. Michael?
Good morning, everyone. I'm Michael Oyster. I'm the Choice Model Contract Administrator and the lead for the Adult Mental Health team.
I am Liz. Oh, I'm sorry.
Please.
I'm Liz Cancel. I'm new to the Home Community-Based Services. I'm a senior policy analyst with the team and one of your facilitators for this session. Today we are going to work together on some tips for housekeeping. So we will appreciate that you use the Zoom chat, and we also are going to have an open QA session at the end. We ask everyone to remain muted during the conversation. We encourage everyone to turn off your notifications. This session will be recorded and the chat will be saved for note-taking purposes. For parking lot, please, any topic that arise that fall outside of this agenda, please put it in the parking lot. You also can use the Q&A function that we are going to explain in the next slides how to use it. This is the basic Zoom toolbar. You also can have a slightly different one. Please, on your left side, you are going to have your mute and unmute button. Keep your sound muted, please, until we open the Q&A. The chat is also around in the middle. Closed captions. If you don't have it in the toolbar, if you use your 3 dots, you're going to see the closed caption in the third option from top to down. We don't have interpretation during this session, but in future session, if you need the interpretation services, please let us know with anticipation and we can coordinate that. And if you would like to talk, please raise your hand. That button could be in the place that it's in the slide, or it could be slightly in the middle of the screen as well. Go ahead. For the Q&A, you can have the Q&A button on your Zoom taskbar, but you also can have it in clicking the more in the 3 dots, and it's around in the middle. Okay, and with that, we would like to welcome Holly and Rochelle to give us a message.
Hello, everyone. I see Rochelle is here on screen too. First of all, just want to emphasize what Liz said at the top. It's so great to see so many people here. Just a little background. We rolled out some office hours last year. We'd had about 5 months of office hours for the community mental health programs. We of course know there are a lot of operational issues that we need to work through together as providers, system partners, to make sure people can access home and community-based services for people with behavioral health needs under the 1915I. And we saw a lot of success in 2024 with just some simple low-hanging fruit operational changes we needed. And then we, did set up some other spaces and forums to try to tackle some of the bigger, more complex issues that were brought up in the office hours. So that led us to taking a deep breath and pausing before we really launched in fully for 2025. And we grew in number here as we really wanted to start a conversation along with the CMHPs, the community mental health programs. We have heard loud and clear in some various settings from the residential providers in the state that are trying to figure out how to operationalize home and community-based services. We hear you. It's been hard, and we are here to try to address these issues. I'm not saying we're addressing them all today. We can't do that. But we are setting up this space so it's sustained over a period of time to tackle issues. We think we have a lot of the right folks here from the Oregon Health Authority to really start tackling this meaningfully with you. We can't help ourselves. We always have slides. We have slides to start. I promise you this will be soon moving more to us listening, taking your questions, listening to your concerns, and thinking through how we collectively work to make the system better. We all want people to be served in the system. We all know that we got to figure out the throughputs. We got to figure out how to get people in the right services, in the right setting at the right time. And then when they're ready to move to their community, how do we help them thrive there? That's it. That's what this underlying purpose, the whole thing, that's what we're here for. So that's a lot of words. I'm going to turn it over to Rochelle to see and to get her additional perspective as behavioral health leadership in this state.
Thank you, Holly, and good morning, everyone. My name is Rochelle Murray, pronouns she and her, and I am the manager of adult mental health services over in behavioral health. I'm here this morning on behalf of Samantha Byers, who is our adult behavioral health director, and also representing the other units that are within behavioral health, the adult behavioral health service delivery that is also under Krista Jones. As Holly stated, we have heard and listened to you all. We have increased our spaces where we are coming into to listen, to be, in the present with you. And so on our end, behavioral health is really here to support the services that Medicaid pays for. And what that means is we're here to help with any technical supports that are needed, being able to understand what the OARs mean for you all and also the people that you serve. So, what do they look like for a person receiving services? And being able to tackle those areas that are presenting a barrier, a conflict, or needs updating because those OARs worked in 1994, but no longer works in 2025. And so we work with Medicaid very closely, very intertwined, because it is one system. How the services are paid for is not really, I think, where we want to focus, but also it is important because for you all, to be able to continue to not only provide the services, but also sustain them and maintain those services, and to be able to evolve when the environment changes around us. And so we're in the space to listen, to really take into account your feedback, and being able to make that a realization for the people getting services. So screening people in versus trying to screen them out because that OARs or statute is no longer working in 2025. So thank you for being here.
So this is Michael Oyster again. Let me highlight the people who will be really a part of ongoing webinars and listening sessions, both here and to come. We've already mentioned that Sam Byers isn't here today, but she's certainly supportive of this process. Let's turn to Cassie.
Good morning, everyone. Thanks so much for joining. My name is Cassie LaVue. I use she, her pronouns, and I am the Home and Community-Based Services Policy Manager here in the Medicaid Division at the Oregon Health Authority. I want to introduce a couple folks from my team. You've already met Liz, who is our Senior Home and Community-Based Services Policy Analyst. We also have from my team, Natasha Martin, who is our 1915I Medicaid Policy Analyst. Also from our Medicaid team, we have David Sant, who is, again, as we mentioned, not here today, but is one of our senior policy analysts and subject matter experts for the 1915I program. We also have Greg Tippett, who is our CoMagin contract manager, and works very closely with CoMagin Health and also our Medicaid team. And I am going to pass back to Michael to introduce some of our behavioral health colleagues.
You bet. So I don't know if Connie is here. I didn't see her come in, but Connie Rush is the Behavioral Health Policy Manager for Licensing and Certification. Connie, are you here at all? No, but she will be, and I'm sure that you'll want to be hearing from her for clarifications on new OARs that have been coming out and that sort of thing. Megan Harper, I don't know if Megan is here, but she's the Operation Policy Analyst for PSRB. Megan, many of you know Megan. Megan's great, a wonderful problem solver. Lisa Nichols, is Lisa here? Lisa's the Intensive Services Manager, who works really close in collaboration with adult behavioral health with Rochelle. Is Rick here? I think I saw Rick.
Yeah, I'm here.
Introduce yourself and what your role is, Rick.
I am Rick Wilcox, and actually it should read Team Lead Extended Care Management Unit. What we do is we facilitate hospital discharges at this point. The purpose of our unit is in transition, and so later on we may be taking a more intense role or a more involved role with actual home and community-based services. But right now, we're assisting in aid and assist discharges. So welcome, everyone.
Great, thank you, Rick. Appreciate it. We did do some hopscotching through here, which is testing my memory ability here. I think I actually saw Greg come in. It'd be great if Greg could introduce himself. Good person to know.
Yes, hello everyone.
There we go. Hi there, Greg.
Hi. Yes, I'm Greg Tippett. I am the IQA contract, CoMagin Health Contract Administrator, and my role is a Clinical Care Coordination Quality Assurance Administrator, rather. Excuse me. And so I focus on a lot of different things, but one of the main things is really making sure that there's a connection between OHA and CoMagin Health, and those processes are benefiting beneficiaries to get the services as efficiently as possible.
Can I just bust in? I want to say something to all of the providers that are like, okay, all these people. I want to say what's significant about Greg to you right now. There was no Greg 2 years ago. We at OHA are moving to expand the quality assurance team over all of our contracts, including our independent qualified agent. So Greg's really important to you when things aren't getting answered, stuff's not coming in, you're frustrated. Who do you call? You need to call Greg. Just want to be really clear about that. Sorry, Greg, but you're gonna need to advertise your email and the whole bit there for everyone.
Yeah, good. I think could we just go back? I didn't want to leave anyone out. I do want to recognize Todd. I'm not sure if Todd came in, but he's the contact for the center manager and the provider enrollment. Really critical role. As well as Marcy. I don't know Marcy. Did Marcy come in?
I'm going to say something cool about Marcy. We didn't have a Marcy. She's another part of that quality assurance team. And we just used some federal dollars that we have one-time dollars. And we are working with Marcy and Greg to expand care coordination directly from OHA to help with 1959 home and community-based services. We don't have them yet, like the ink is drying on the contract. We're hiring in these care coordinators. There will be 8 across Oregon. They will represent geographic areas. So you'll have help in your area, trying to think through how to get people in and out of these services in a way that makes sense as a network and an ecosystem locally. And I think some to what Rick was talking about, like we all know how hard these hospital discharges are. We get stuck. We're trying our best given everything else going on. We're also going to have those care coordinators take on specialized issues like his hospital discharge, or maybe we need a care coordinator just focused on people with a disability and a behavioral health need, and really be specialized in helping that group of people. So definitely think about Marcy, definitely think about Greg. They are a team over there. We're trying to free up some systems in Medicaid to be more helpful on the ground to get people moved where they need to go.
Marcy is
Great.
not here right now, but she is going to join us around 10.
All right. Very good. Thank you. Thank you for the further orientation. And just to be clear, I'm Michael Oyster. I'm from the adult behavioral health, but these are all of my Medicaid friends. We can't do this without each other, which really leads me into this transitional section of that. David Sant and I are going to be hosting in ongoing webinars, case consultations where specific PHI wouldn't be shared, but we would have an individual that we're thinking about as we're referring to a systems challenge that we all need to really get together and figure out a solution to make those routes more direct. So often our system is so complicated that we can carve out individual routes to solve specific situations, but we don't have yet a direct route. We're wanting to both solve those specific situations in addition to developing that direct route. So be looking forward to that in future webinars. Let me turn it over to Bonnie.
Sorry, I had to find the unmute in Zoom. Hello, my name is Bonnie Barron, she, her pronouns, and I am a new HCBS 1915I enhancement analyst. Have been at OHA for a little while, but transitioned into this role. And so we are excited to be able to share with you our upcoming series that's going to be happening, hopefully ongoing forever. And it's going to be inviting residential providers, community partners, CMHPs, all of those that serve 1915I consumers to webinars and engagement sessions that we will be able to present topics to you for education, topics of interest that you have highlighted for us already in the amazing registration that we've got for the April 23rd webinar coming up. And also then engagement sessions where we can actually just have some shared, communication and best practice sharing, and highlight some great practices that we're seeing from our providers. So this first one coming up is April 23rd, so it's relatively soon, and the invitation was sent out. So if anybody needs that, feel free to put that in the chat that you would like to be added to the list for the webinars. And it's going to be a webinar one month, an engagement session the next month, and we'll kind of alternate in that way. The first one will be for our home and community-based residential providers who provide service to those members. And we will have, subject matter experts from OHA and other experts to address barriers for and foster community engagement and identify training topics for future sessions. So like I said, the first topic coming up is really going to be a basic level setting, but also kind of some foundational understanding of what HCBS is and licensing and provider information as well. If my screen doesn't show it well, but it is on April 23rd from 9 a.m. to 10:30 a.m. And there is a requirement to register, and those will be recorded purely for note purpose taking so that we can get your great ideas and keep bringing you new information. So I will pass it back to Michael.
Great. Thank you, Bonnie. Appreciate it. And speaking of HCBS, I think Cassie has more to share with us around HCBS going into the Q&A section.
Hi, folks. Well, first of all, I want to say that I'm really excited that we have both this series and our webinar series coming up. It's really meant to synergize between what comes up here in our Q&A sessions or case staffing to help build out more focused sessions around things that resonate with you as providers with what you're seeing with your clients actually in the settings that you're in. So I'm really excited that we're able to bring this all together, and super excited that I saw a lot of folks in the chat adding their emails so that we can make sure we have as many invitees as possible. So thank you very much. We'll make sure that the link to register to the webinar sessions goes out along with our notes. But again, if you don't receive if you still don't receive that, there is a 1959 Medicaid policy email address right here on the slide. You can reach out there and let us know, and we are happy to send you the link there as well. So we spent a lot of time kind of level setting what these sessions are going to be about, who you might see. We're going to definitely have a consistent cast of characters from Medicaid and behavioral health, but depending on what questions we get from y'all in the Q&A function in the Zoom meeting, we might rotate some folks in that you haven't seen or haven't worked with frequently, because we want to make sure we have the right subject matter expertise in the room to talk about the things that are most immediately needed for you. So while you might see a little bit of a mix up of staff here between Medicaid behavioral health, Comagin Health, and Accentra when we get those folks onboarded, know that you're always going to have representation from Medicaid and behavioral health here to answer questions. And if for some reason we can't answer those questions during the meeting, we are making sure that we catalog those, we track those, and we get you guys responses before the next session. We at the state side have done a lot of talking so far in the session, so now we really want to transition it over to y'all. What are the things that are maybe presenting the biggest challenges or barriers for you? We do want to leave some time in this session to really hear from y'all about this structure, how we can make that more supportive for you, or actual issues or challenges or questions that you have regarding the people that you serve and the work that you're doing. So I'm going to stop talking and let folks either come off mute, put in chat, or raise your hand, and then we will just have some open conversation.
So, there's a lot to digest when we've been talking for the last half hour or so. So the transition into the space for Q&A is sometimes difficult. But, I know that there's been some desire of wanting to really implement 1959 services more across the state. We've had several different kinds of sessions to get some ideas about those processes. And I just wonder, about differences in different areas. Things are not the same across Oregon, right? We have very different areas, and I really want to give everyone here the ability to voice those differences and some of the challenges and opportunities that you have in your particular part of the state.
I'll just say you can be blunt. Like, it's okay. We know things aren't working all that well. Just lay it out for us, because we can't begin to address and really fix it unless we're hearing from you directly. And then we're here as a team and we really wanted to be here. I think you got the point. Like, we're here. Everybody we think that needs to help fix this stuff.
Do you see we have a question in chat and we have a hand raised as well? Matthew, do you want to come off mute and share your question, concern? And then I think Kyla, we can tackle your question.
Yeah, so this is Matthew Eldridge. I am the CMHP representative for Jackson County for the AFH programs. Our providers are feeling like I was on the rack, so I have a really strong understanding of what's happening with these OARs. But the providers are feeling like that there needs to be more direction coming from the OHA on how to meet these OARs. So far, we've had 2 unannounced visits under the OARs. And the citations are limited so far, but providers, due to the level of technical assistance that we're providing, are succeeding, but it's kind of a burden for the CMHP that's not the licensor to be providing technical assistance that's possibly not in line with what the licensing division is going to be either citing or not citing. And can there be more Zoom meetings for the providers to be getting their questions answered and have the CMHPs included in that, so we're giving the same technical assistance that OHA wants us to be giving?
I heard written guidance, Matthew, from OHA, as well as maybe really teeing it up in spaces like this, where we've got Medicaid and the behavioral health division here with CMHPs and residential providers to actually provide that technical assistance. Is that what you're thinking?
Well, I mean, the written, I will support the written in that. I mean, we did get the log at the last meeting that Clay and Michael Oyster and such were at, and I released that to our homes. But then giving that log, I've had to give some context to the best that I can on how to fill out that log, how to make it make sense. But then again, that log's more for Comagin's purposes for the 410 OARs, and now those are embedded in the 309s for consistency. But at this point, we're doing our best to make sense for our community providers while possibly being in error. And I don't mind as a county official doing that, but it's quite the burden for the county to put ourselves in that position to be the authority when we're not the authority, and we're not Comagin that's utilizing it. We're not the licensors here in Jackson County, at least, that are inspecting the homes. So, you know, it's not enough to give a document as much as it is to give an interpretation of how to use that document. And I think we like what's being given, but having an interpretation of how it's used is the issue, I think.
Yeah, you know, certainly that document was supposed to be a guide and a tangible process to communicate services being delivered and clients who have those specific needs. In the announcement, it was intended to have people go to licensing and certification to Connie specifically about further questions about that. What I hear is a certain nervousness about helping people process what that policy is and the context for it and the such. And certainly we want to partner with you to provide that bigger context and that support so that people know how to use the form and the process to their clients' best interests. Certainly technical questions, refer those to Connie. And just realize we're wanting to partner with you in contextualizing and processing that with your providers.
And to follow up on that, Michael, we will always refer our homes to their individual licensors. In this case, Clay and Chris are the two here in Jackson County.
Yeah.
We have confidence to answer some things, but where there's a question, and then we're asking them to include us on those questions so we can get, for the benefit.
Good.
But I think that's the thing that we're hearing, though, is we got this, but what's the interpretation?
Interpretation. Yeah, I hear that. Thank you.
I want to add a couple things. I think probably Connie and Greg together would be a pretty strong combo, since Greg is truly the one who is the conduit to the IQA. And Matthew, what I heard you say is a lot of this is in the 410, sorry to be technical, 410s, the Medicaid rule set that's now embedded in the behavioral health rule set. And that it's really a lot of questions around how to get that paperwork that's needed filled out for the IQA. So don't be afraid, put Greg and Connie together as a dynamic duo in trying to make sure you get the technical assistance. And then I just got to add one more thing for everybody in the space. Many of you participated in helping us pilot a new assessment tool in OHA, and we will be coming back to you soon, either as part of this or the webinar series or both that we laid out prior. But I think listening to you, Matthew, and watching the chat and hearing input well before this meeting, we know we need to do a better job as we roll out NRI later this year, and really not just doing the early engagement where we're like, here are the findings, what do you think? Talking through that, making sure the tool's comprehensive. But I'm hearing an ongoing technical assistance to make sure that providers can really leverage these tools as is appropriate in working with OHA and the IQA. So I just want to say, I think that it's a yes to what you're saying right now, and an acknowledgement that as we change out these tools later this year, we need to build in more TA around that.
Holly, I will meet you on that, but I also feel like there's a responsibility that the homes, first of all, the RAC was poorly attended for whatever reasons, and it was an awesome opportunity afforded and liberally allowed to attend, either as members or as community. The homes, by and large, missed that opportunity for whatever reasons. However, the enforcement of the rules is where the question becomes. If you miss the opportunity to engage, at least having the enforcement of those rules being made clear. But somehow the responsibility must be accepted that missed opportunity by homes to participate was missed.
Matthew, I think we've got a lot of action items to take away from just your comment and the conversation overall. So thank you very much. And I see that folks have kind of resonated and validated that in the chat. So thank you, everyone. I am going to move on to Kyla's question. And Kyla, please tell me if I'm saying your name wrong. I want to be correct. But Kyla, you wanted to talk about Lines for Life and managing the referral process through that avenue.
Yes, and you are pronouncing my name correctly. It's terrifying to mark open for a wait list on Lines for Life. The referrals come in at a rate that's not processable, especially with multiple programs. And so combining that with the wait list length expectations, it's really scary right now. I did have the chance to talk to Letitia directly when she was calling and asking for feedback around the Lines for Life process. And one of the things I specifically said was that we are hesitant to mark things open because we get a flood of referrals that we cannot handle. but within potentially minutes. So there was no conversation with providers about how we were going to adjust this. Beyond those phone calls where it was asking for feedback, I personally gave pretty clear feedback about the process and how poorly it's been working for us. And to then just see that being emphasized as the process for getting referrals is pretty frustrating.
So Caleb, what would you recommend as a solution to be able to better manage the flow of those referrals? I certainly hear you. Once you open it up, it's like the gates are open. And even recently, I've heard that there's been some challenges in closing them. So, you know, that deluge kept on going on for an entire day. Perhaps that was your program. What would you recommend as a way to be able to better manage that flow?
I don't have a specific suggestion. I don't know if maybe the state needs to have like a set period where they're checking in with programs saying, are you open for wait lists? And helping to manage that. I understand that it's supposed to be increasing accessibility so that it's not just, oh, hey, county, we're ready for referrals, and then just getting specifically from one county.
Right.
So I don't know if maybe having like each county is making a referral to one program when things are opened, but the current system's not great because it still is it's still setting up for that same kind of thing of, oh, hey, county, we're going to be opening our wait list. Oh, it's open. Cool. I'll send referrals. That's not helpful either. So
Right. You know, just as we're talking, I wonder if, and I don't even know if this is possible. Okay, so we're just brainstorming here, but it's like a counter that you could actually open up. It's like, we're open for 10 referrals or for 5 or whatever, right? And once they were made, there would be a counter of some type, of which we don't have in place yet, but I'm just brainstorming. Once that was done, then it would automatically close. So that's what comes to my mind just as we talk. Would that seem to meet the need?
that's if there's some way to just have, as people are submitting them, that they are marking off that they're submitting a referral to that program. That could be something that could be really helpful.
Yeah, we would have to add in another layer that we've been contemplating actually. So I think there might be something like that on the horizon. So let us work on that. Thank you.
Thank you.
Find my mute button. Thank you for sharing that, Kyla. All right, our next question is, so we have two. I think one is being tackled through working with CoMagine from Amber, but Amber, I know you had a question in here about why the length of time it takes for CoMagine to hear back from OHA on approval for pre-placement rate assessments. Did you want to speak to that at all off mute, or is there anything else you'd like to add before we throw that to our subject matter experts?
Hi,
Hi, Amber.
I have a camera over there, but I'm watching over here. I think you all figured that out after 5 years.
Yeah.
One of them is, I'm just curious about the time frame from when we submit to CoMagine and we are cross-placing. For example, we already have an approval from OHA Complex Care. We're cross-placing. We get the assessment done by CoMagine, and CoMagine needs to send that assessment out to OHA for approval. And that process between when CoMagine is done and when it goes off to OHA for approval, I'd like to know the time frame there, because I'm working with providers who have likely held a bed for an individual, or they already accepted that individual into their home in hopes that their licensed rate would be presented. But I placed a gentleman in a DD 24-hour program in January, and I haven't said that it's taken that whole time, but he was an OHA Complex Care approved placement, and here it is 4/8, and we still don't have a rate for this individual, and so that provider has not gotten any money. So I'm curious. I understand that CoMagine does the you know, they use the tool that's appropriate for that license setting. And then there is dead air for a really long time. No communication that it's been sent off to OHA for approval, no communication on how long that's supposed to take. And when asked how long that's supposed to take, we've been told there is no time frame. It's just when it comes back. So is there not a contracted amount of time? I am a previous KeyPro employee, and there was a deadline of every single time of something was submitted. And once it was submitted in completion, we had X amount of days. And those days are long gone. Those X amount of days, I'm not even sure how long a PCP takes anymore, because I put one in on February 18th and we're still waiting for the PCSP to be completed. So these are really big concerns because they are impeding providers from getting paid in a timely manner. And I have two very frustrated providers that I can't seem to get two conundrums fixed for them. One I just sent to Nikki. I couldn't forward the Comagine thread to her, so I just sent the particular person that we are waiting back from OHA to approve their cross-placement rate. And the other individual, I can't seem to fix 6 weeks of their Medicaid that was turned on. And I have sent that on to Greg. So I am in the path of trying to get those two things fixed. It just seems like the communication level is really minimal and there's no time frame. So I just keep checking back and checking back and checking back. And Comagine just says, we haven't heard back, we haven't heard back, we haven't heard back. Where is our direct line to know where this process is and not having to complete Comagine in the middle of this when OHA isn't giving them answers either? That's my
Amber,
question.
I'm just going to say out loud, I'm a little surprised because, and I'm glad you're bringing it up right here. I've been
It's good to be
tracking it.
honest.
Yeah, I've been tracking it from a different angle where when I see nothing's going to the rate review committee, that tells me, or it's an indicator for me, that we are moving through any rate exceptions or rate issues and we're doing okay. And clearly there's a breakdown because you're telling me, and I'm seeing the chat light up, that there are still outstanding issues. So I think we need to take that back. We are messing up on our side. That's us. So we need to take that back and we need to figure out where that breakdown is and we got to fix it. And I also hear your other comment, which is you need to know where things are in the system. Like, did it go to the rate review committee or is it still in consideration, or when we did make an effort to get these things turned around within a number of days. And we were, the last I looked, we were meeting that mark. We're clearly not now. So we're going to go take that back. That's really important feedback and we need to do something about it. So thank you. Oh, Amber, you're on mute.
After 5 years, I'm on mute. Look at this. People are coming out of the woodwork. Hey, you remember me? Yes, Andy, I remember you. Long conversations you and I had, bud. It's almost detrimental when you worked for the IQA at one time. Thank you for letting me talk, you guys.
Thanks for sharing, Amber. Okay. We are gonna move to Tammy's question in the chat. And I'll just say it out here for the recording too. The interview with aging and people with disabilities creates a challenge for us. In the past, it's felt like if a person has met the 150% income guideline and the behavioral health needs criteria, they would get 1915I. Now they are required to do a resource and asset interview that can take up to an hour or more. And we have had individuals who have lost their OHP because of this. And I just want to echo that there are some responses to that comment in here, just confirming that that is something that is still happening. Tammy, is there anything else that you would like to add or anything else that you wanted to come off mute and share? That's okay if you don't, Tammy. I know
Another comment at the bottom, her mic isn't working.
Yeah, go ahead.
Says, should there be two different pathways for individuals that need 1915I Medicaid to support them in the community, more like the standards for standard OHP? Sorry, my mic isn't working.
That's okay, thank you. With regard to that question, I know Tammy, you and I have and a couple other folks here have gone back and forth via email about this. It is a process that we are working with our partners who work in our organ eligibility partnership team to really figure out where that process is breaking down. Oops.
We just use what we have.
Okay. And I think we have we don't have any of those folks from the organ eligibility partnership here today, but that is definitely a team that we can bring to this space, because I know that that continues to be an issue. So we will also take that back and get you a formal answer, Tammy, when we've got some of that process nailed down. And then definitely want to hear from you throughout any work that we're doing to kind of map that out differently and change the way that that is processed so that it doesn't continue to happen. I'm going to move to our next question in the chat, which is around the timeline on hearing requests regarding the termination of residency being concerning, especially when the resident isn't occupying the bed. Again, I hope I'm saying this name right. Kiter, if there's anything else that you wanted to add, did you want to come off mute and share?
Hi, it's Kiter.
Okay, thank you.
So I guess this case right now that I'm going through isn't like concerning right now. I'm hoping that the resident actually does come back to us. But I guess in the future, if I do have to go through the process again with another resident that is more like aggressive or behavioral concerns, I guess the timeline is very concerning, because our hearing, so we did the pre-hearing for the actual hearing, and it's 45 days out, which is actually pretty concerning, because if like there's a resident that is, say, smoking in the home or setting fires in the home or is aggressive behaviors, like that's actually really concerning that the hearing isn't until 45 days out. So we have to keep that resident like in the home, or, you know, that's concerning to me. I don't know why we went away from the appeals and went to the hearings. So I guess, is there a reason why we switched? Or I guess I'm just, you know, curious, and if anybody else has gone through this, or I just want to know more about it, I guess.
And are you talking about the process of discharging an individual because of those behaviors?
Yeah, like
Right,
if they try to, you know, they want a hearing, you have to go through the pre-hearing first, and then the judge has to set the hearing, and it's just so far out. You know, the actual termination of the residency could just be extended so far out, and then if they appeal the decision, that could be extended even further out. So it could be, you know, several months before, you know, it actually happens. So it could be very concerning if, you know, they are trying to set the house on fire, or they are, you know, being aggressive, or say that they ended up going to jail and they ended up having to come back to the home and the victim's in the home. Like, how do we deal with that as a provider?
Okay. I do think that we need to connect with our hearings team about that to see where there might have been process changes, and if and make sure that those were communicated out, and just to see where that happened. But I definitely hear you, Kiter, with the complexity of the process around the discharge and potential dangerous behaviors from a resident, that it's not new feedback for us. So we know that that is an issue and a challenge that y'all face. I would like to spend some time with our hearings team to understand the process, to understand if the way that the process is working on the ground for y'all is what the intention behind the process is, and how we can make some improvements to that, to help you guys figure out how to handle these complex situations. So we will definitely set that up very soon with our hearings team. If there's specific any more specific cases or specific details that you would like to share with us, so that we can make sure to really talk through a lot of the different complexities that you're sharing, please feel free to send it to that 1959 Medicaid policy inbox, or me directly. I could drop my email in the chat here, and would be happy to pull that through to the conversation and get back to you.
Okay, thank you.
Yeah, of course. Okay, sorry, I scrolled down all the way to the bottom of the chat. Now I have to go back up. Let's see.
Maybe Cassie, while you're looking, I'll just say, yes, we know we need to discuss some of the things in home and community-based services that are difficult to operationalize in a residential setting. I just want to acknowledge that in this space. We have heard that loud and clear, and we understand on anything that could be a danger to the person, to other residents, to the staff. And it's not simple, but we know that's one of the major things we need to tackle right away. So that is heavily weighing on us here at OHA, and we're trying to think that through, and we will be engaging you as we come up with some different concepts.
You know, one thought. This is Michael. I just want to offer perhaps a couple thoughts about this kind of situation. You know, a program always has dedication to the entire group of people, right? And you need to be able to address the clinical needs of each person. Even during a hearing process, though, if someone is destabilizing, you still want to be intervening with stabilizing measures, and that could be everything from hospitalization to respite to additional services and collaboration with the CMHP or the CCO to address those needs. You know, we don't want you to be with a client and just having them in suspension during the administrative court process. You still want to treat them and treat the needs that they have, which also then better serves the rest of the environment too, the rest of the clients. So sometimes I think because we see a client in administrative hearings going through appeals and all of that, that we're kind of stuck. And you know, yes, I mean, you can't evict them, but you still need to treat them, and you can treat them in a variety of different ways that supports their increased needs. So please keep that in mind, and feel free to reach out to us and program as well to brainstorm over those strategies.
I don't see any new questions in the chat. I do want to acknowledge we got one in our Q&A function regarding, I think, something that we've talked about already, which is being more clear around specifics in our OERs. This one was an anonymous Q&A, particularly regarding the requirements about management structures in our OERs. So if that person is here in the room, what I can say is we will take a look at that portion of our OERs. If there is a specific question that y'all still have that you feel like hasn't been answered, please send that to our 1959 Medicaid policy inbox. And rather than pointing you back to our OERs, which you indicated as an issue, and we certainly understand that, we don't want to continue to point back to OERs that are not clear or are not specific enough for y'all. We'll work with you to understand what the actual challenges that you're facing and filter that through the OERs to see how we can really support you and make the process work for you and your facility. So we'll have that answer back out in our notes, just because the question was anonymous. I do want to acknowledge that we're almost out of time, but we do have one more slide to share just with some upcoming events. So Peyton, if you could throw that slide back up on the screen real quick, we'll announce that and then we'll close out.
Thank you, Cassie. And I'm going to reiterate that if you have any question that wasn't answered during this session, we will review this. We will have all the notes for the session as well, hopefully an answer for you, or reach out to you. We could reach out to you also as well. Continue sending also your comments or questions directly in the Q&A from the office hour invite, or you also can send us an email that was also added to the chat. I want to give you a heads up that there are future events coming up. So the next office hour will be Tuesday, April 22nd from 9:30 to 10:30. We will send the invite and more information soon. And also you should receive an invitation for the OHA residential provider webinar. And this is also targeted residential setting providers, but everyone is welcome as well. And that is April 23rd from 9 to 10:30. And the next community mental health program provider office hour will be May 13th from 9:30 to 10:30. And as I mentioned in previous one, everyone is welcome to all these sessions. Doesn't matter who is the target, but just so have that in mind that the topics are going to be targeting those specific audience.
All right. Thanks, Liz. I'll go ahead and close us out. Thank y'all so much for coming and joining today. I've seen a few comments in the chat that having this space and being able to talk to people in real time has been helpful. It helps you see movement in some of the cases or the situations that you're stuck with in your facilities or with your clients. So we do want to acknowledge that we're glad that this space is helpful for you. We definitely will be continuing to have this space, and it can refine and iterate as it goes on to meet your needs. Just feel free to send us any and all feedback that you guys have about what can be helpful, what can change, what you like about this structure. And I can commit that we will always try to facilitate the most relevant subject matter experts to be here to answer your questions, either live or via email. We're really here to hear you and to improve these processes and to make home and community-based services work for y'all, and most importantly for the people that you serve. We know that these challenges impact you as providers and the people that you see, so we definitely want to work together and co-create solutions with y'all, and that's what we're here to do. So thank you very much. We'll see you at the next session in the next webinar, and I hope y'all have a wonderful day. Thank you so much.
Thank you, everyone.
Thank you.